Thank you everyone for joining us tonight on the East Sussex Eye Group, our latest webinar, which is our 32nd webinar.
Oh,
Just
really?
for people that don't know what we're about, we East Sussex Eye Group started in during COVID. It was Mr Kashani's idea to set up a group to help with. We have a WhatsApp group where people can ask questions for the consultants, and we do webinars to help sort of in community with mechs and patients that are a bit complicated, how to deal with them. So that's how we started, and we have Mr Kashani, Mr Qureshi and Mr Ionidis, who are our consultants, and they all take turns in doing webinars for us. So we are fortunate tonight that Mr Kashani has written a webinar for us. And so this webinar is said I'll be able to record it and I'll put it on our social media channel afterwards. There is one CPD point available for optoms and DOs if you're watching it live from your link and you've registered with the details. And I will try and get the CPD certificates out. I get 2 weeks to send the certificates out from the GOC, but I'll try and do it at the weekend. It's voluntary, so I don't do it in work time. It's in the evenings I do this, so I'll get the certificates out hopefully within the next 2 weeks. The lecture will run for about 45 minutes, and it's a very interactive lecture, and there'll be polls for questions that Mr Kashani has written for us. The answers are anonymous, so nobody will know what you've answered, and so please feel free to answer. If you don't know, just have a go, have a pop, and Mr Kashani will talk through the answers at the end. There is also a Q&A box at the bottom of your screen, so if you have any questions, please feel free to type them in there, and at the end of the webinar I'll then pose these questions to Mr Kashani to answer for us. So our speaker tonight, Mr Kashani, I'd like to welcome him along. He's an ophthalmic consultant surgeon at East Sussex NHS Trust, specialising in the management of complex medical retina disorders. He performs intravitreal anti-VEGF injections and steroid implants, anterior and posterior laser segment treatments, as well as high-volume cataract surgeries. He has previously been the clinical lead for East Sussex NHS Trust and is now the head of retinal services and uveitis. Tonight he will present a webinar to us on, well, originally it was called a selection of interesting cases, but when I got the slides on Sunday, it was changed to miscellaneous cases quiz time. So I'll look forward to it. So thank you very much, Mr Kashani. I'll pass over to you.
Thanks, Ian. So do I share now?
Yes.
Share this one. Okay. Can you see it yet?
I can't see it yet, but it might be a bit of a lag.
Oh, just did it.
This worked 2 minutes ago.
Hold on, let me just go back. Hold on. Okay, hold on. Yeah, so if I go to maybe. Right, what about now?
Yes, it's coming up now. Yes, we can see that. It's in normal mode, so
how's that?
presenter mode. So yeah,
Now?
perfect. That's
okay.
Perfect.
All right, okay, thanks, Ian. Okay, thank you very much, Ian. Very kind of you for that introduction. I think we've generally carried on, well, whenever I've done it, these kind of selections, actually most of them are patients I've seen in clinic, and I've decided to take a picture on. So they are kind of East Sussex patients. Occasionally I'll have other kind of patients join in. Please feed back to Ian if you'd like to go back to kind of more lecture-based stuff on various topics that you might find interesting rather than kind of selection of cases. We are also planning to do a peer review, I believe, which Ian will let you know about. And at some point, I'd quite like to do that round we did again for you guys, which I think we did that last year. So maybe in a few months' time or early next year, we'll do that. Okay, so here is my kind of financial disclosures, my email, which most of you have if you have any queries, and the rest. So case number one might be familiar to some of you. I promise you the rest are not. I've only mentioned it because we've kind of discussed this before, and it still causes a bit of confusion. So I've decided to kind of include it again. So this is a question: which one of these conditions, and the answer is only one of them, would you be concerned about with regards to wanting to involve a gastroenterologist? So I promise you, and I'll give you 20 seconds. We really are not going to know who's done what, so please feel free to just type in whatever. I'll let Ian kind of decide when to close it. Okay, so we've got majority saying A, some saying B, some saying C. So B and C are equal and nobody saying D. Okay, that's good. So the reason we, thanks Ian. So the reason we mention the gastroenterologist is because, as many of you know, these are not choroidal nevus. These are kind of retinal pigmentation that we often see in the back of the eye. And the correct answer is A. As you know, there is a particular type of kind of retinal pigmentation that is associated with familial adenosis polypi. That's a gastroenterological condition which will lead into cancer in the gastrointestinal system. And it's an autosomal dominant condition. So it's kind of goes through your family. But it causes a lot of excitement because when people see chirpy, they say, right, this is the one that I need to worry about and I need to send. So let's just start from kind of the easy one. So B is a typical chirpy. So chirpy congenital hyperpigmentation of retinal pigment epithelium. It's very black, very dark, looks different to nevus because choroidal nevus is in the choroid layer, so it will not look as dark. Very well circumscribed, and it shouldn't or doesn't really change in time. Okay, so B is a very typical chirpy. The picture in C, which I've taken off and referenced for you, is what we call the bear track. So a lot of people see that and think, oh, this is the ones to worry about. That's not the case. Bear track can be unilateral or bilateral. They are not associated with the FAP condition. And again, D is basically like the one in B, but with areas of vacuoles and hypopigmentation. So the ones you should worry about, which could be unilateral, but they're mainly bilateral, are spindle shape, like they are in A. Hopefully you can see me do this. And they've got a halo around it. So if you see spindle shape pigmentation like that in the back of the eye, with evidence of the halo kind of around it, those are the ones that you need to worry about. And yep. So this is what we call the atypical chirpy. So I've got the picture there again. So it's associated with these conditions, which you don't want to miss. Multiple, bilateral, they're widely separated, and they're oval spindle shape. And as I said, there's hypopigmentation. So please don't worry about your typical chirpy, which is the pigmentation shown in picture B. Don't worry about the bear tracks. Okay. So I know some of you would have seen that from before because I have done it before, but the question came up, and so I thought I'll show it to you. Now, this was a 45-year-old lady who came to see me because she was worried about her vision. And these are the pictures that I see. So she's type 1 diabetic, but the visual acuity is 660 in both eyes. And she's had previous panretinal photocoagulation in both eyes. So you could just see in the right eye, top of the picture, some PRP scars, okay? And then my question is, when you see somebody like that, so that's like your slit lamp view, all right? What do you think is the most commonest cause for a visual acuity of 660, which is quite poor, all right? So could it be cataracts? Is it active proliferative diabetic, so new blood vessels on the disc or in the retina? Could it be foveal ischemia? Or is it vitreous hemorrhage? So I think we give them 15 seconds actually. And so if you could put the poll up. Okay, so excellent. So 60% got that absolutely right. So let me tell you why it's not cataract. If it was cataract, then you shouldn't be able to see the fundus picture so well. So if somebody has got cataracts, you will not be able to see the back of the eye that well. And often this is a problem when you're trying to look at patients with retinal disorders or glaucoma or anything else. How much is the cataract? How much is the back of the eye? And just use your common sense. You've got to think, well, I can see the back of the eye really well. There's not been a big refractive change. Therefore, cataracts cannot be contributing. Another thing you could do is to look at both eyes and essentially see if the vision is really good in one eye and not good in the other at all, but the cataracts are the same, then it can't be the cataract. Active proliferative DR is unlikely to be the cause because new vessels on their own don't reduce the vision. They just indicate that obviously there is active ischemia going on in the back of the eye, but new blood vessels on the disc or other parts of the retina wouldn't reduce your vision. It can't be vitreous hemorrhage because if there was vitreous hemorrhage, you wouldn't be able to see the back of the eye. So it has to be foveal ischemia, which is a condition you can get in diabetes, vein occlusion, loads of conditions actually, and it's quite difficult to see. So my next question is, with the same lady, what would you do in order to kind of clinch the diagnosis? Would you do fluorescein angiography? Would you do a B scan, ultrasound? Would you just do an optomap of the retina, which I know a lot of you guys have that in your system, or would you do visual fields? So if you could have the poll again, and I'll let Ian close up after 15 seconds. Okay, so what have we got? Good. Again, quite a good mark, probably the 60-something% that said foveal ischemia, said FFA. So B scan is really useful, an ultrasound which we can do in clinic. If you've got a vitreous hemorrhage, and the only reason you do a B scan is to see if the retina is still attached. So you can never assume in a diabetic, when you've got no fundal view at all, that your retina is still attached. And of course, that changes the whole game plan with VR intervention, vitreoretinal intervention, if you've got retinal detachment, makes it urgent. But if it's vitreous hemorrhage on its own, then often they can wait for a few weeks or even months before they get operated on. So B scan is not correct because we don't think there is vitreous hemorrhage. The other thing that we mentioned there was the optomap. Again, optomap, yeah, will show you what's happening around the retina. But again, you know, as I said, we know that this is foveal ischemia. So optomap is very useful in these kind of patients, but it doesn't tell me what's going on here. And again, visual fields, very good test if you're worried about optic nerve disease or anything like that, but not if you want foveal ischemia. So fluorescein angiography is what you need. And this is a really good classic picture of foveal ischemia. So what I want you to see is when you inject a fluorescein dye into the patient's arm, it should take about 13 seconds to get to the back. It will perfuse the arteries, arterioles. It will go through all the capillaries. You get like a capillary flush, then veins, and that's it. So when you're looking at a fluorescein angiography, what you should see in the back of the eye is a very small circular area of darkness, i.e., what we call foveal avascular zone, or FAZ. Okay, foveal avascular zone, and that's about normally a third of the disc size. Okay, but what you can see here is, look at this FAZ. So it starts off with this edge. I hope you can see my arrow, and goes all the way out here. So you can fit 1, 2, 3, 4, about 5 discs in that area. And this is a more magnified view. And what you can see is that your choroidal flush is really gone, because when you start looking beyond this point here, okay, all this area is black, which means that there is complete ischemia in the periphery. And the kind of blip over here is new vessels. So new vessels tend to occur at the junction of perfusion and non-perfusion. So this patient has extreme non-perfusion, but that's the peripheral retina. And the reason she can't see is foveal ischemia. And this is the other eye. So I've got a really good magnified picture here. You can see that foveal vascular zone is massively enlarged, and that's why she can't see. There is nothing you can do. You cannot laser this patient. Some of these patients will have macular edema, okay? And you will inject them, the edema will go, but the vision will still be very poor. So what you don't want to do in this kind of patient is keep going with the injections. So if you've got a patient with 6/60 vision, very little edema, and the fluorescein shows that, then your main problem is loss of those capillaries. And if the blood supply is gone, the retinal pigment epithelium is gone, the photoreceptors is gone. So unfortunately, the prognosis for this is very, very poor. Okay, next case. So take-home message with that case was, in somebody where you look at the back of the eye, you think, I can't see much happening with these diabetes, but the vision is very poor, and there's not much cataract, there's no hemorrhage, nothing else going on. Think foveal ischemia. Obviously, you would do an OCT and see how much fluid there is, but in these patients, getting rid of fluid probably wouldn't make much of a difference. So this is a patient who has, I'll just get rid of this here. 65-year-old gentleman presents with this incidental finding at the opticians. OCT over the lesion shows no fluid, and the ultrasound shows that the thickness is around 0.5 millimeter. Okay. What is the most likely diagnosis? Is it wet macular degeneration? Is it a choroidal hemangioma, a choroidal melanoma, or a choroidal nevus? I wasn't going to make this that easy for you, so Ian will put up the poll. So the main thing is no fluid on OCT MAC. You've got ultrasound saying that the lesion size is less than, it's to be around 0.5 millimeter. So what do you think is the most likely diagnosis?
Hi, Shah. Can I just interrupt?
Yeah.
When I put these polls up, the polls come up in the middle of the screen, and I meant to say this beforehand. You can drag and move that polls box aside if you can't see the image. So it was asked to me before about the poll comes up in front of the image, so you can do that.
How is that? Is that okay?
I've moved it, yeah, hopefully, but people can move it themselves, so.
Oh, okay, fine, right. Okay, sorry, I thought you wanted me to move it. Okay.
No, 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 so there we go.
So I've got wet macula. A few of you thought that. Some of you, most of you thought choroidal nevus. Again, that's correct. And let me tell you why that is. So I think the feature of the lesion will tell you it's unlikely to be wet macula. You can get wet macular degeneration, which is not central and a bit kind of what we call eccentric. But the lesions tend to have hemorrhage within them and be more gray rather than nevus looking, which is like that. The clue really was in the text. So if you've got a nevus and when you do an OCT, you would just see that the OCT shows kind of like a dome shape. Or you know, you can see just the nevus is kind of pushing forward in the choroid. If you can get an OCT of macula, but over the lesion, and you can show that there's subretinal fluid, that will increase the likelihood that it's a melanoma. So here we say that there's no fluid, so that's fine. And then ultrasound information, obviously you're not going to have that at clinic, but normally a thickness of more than 2 millimeters is what we would consider risky for melanoma. So the answer is nevus. It's not a hemangioma because a choroidal hemangioma is not that color. A hemangioma, as the name will suggest, will be orangey. And often, actually, if you're looking at the fundus, you might not even notice it's there. What you might notice is that nothing really, you're doing the OCT, and suddenly you see the OCT with a big lump, like as if it's completely raised. And if you can't see any nevus-like features or it's not dark, then it could be a hemangioma. So remember, these are in the choroid. So on your OCT, your retina will look normal, but it'll be pushed or bowed forward with the nevus melanoma or the hemangioma. And I've got a picture of this. So this will give you a historical clue. So this is over the kind of 3 years, and you can see that hasn't changed over time at all. So if you've got that kind of picture, that's really good. Normally, when you send us a nevus, if we think it's worth looking at, then we will follow it up for 3 years, and after 3 years, we will normally discharge it back to you. And that's very different to this, okay? So we've got, hopefully you can see a lesion, which is supranasal in this patient. 42-year-old man feels a shadow in the left eye. So most of you would know that the shadow would be infratemporal, corresponding to that lesion. Ultrasound shows more than 7 millimeters of thickness, and OCT shows SRM. So I hope most of you are guessing what the answer is. It's probably a bit of orange pigmentation there for good measure. What would you do next? Would you refer to the eye clinic routinely? would you ask for an interval picture in your practice in about 3 months to see if it's getting bigger? Would you call the on-call doctor that day, or would you refer to clinic to be seen within 2 weeks? Okay. Good. Again, majority wins. So thankfully, you guys wouldn't refer to this routinely, and you wouldn't ask for interval, because this is as clear as a choroidal melanoma will get. Large lesion. You can see it's very, very big. The patient is symptomatic. The thickness is more than 2 millimeters, which was a clue I told you about, and there is subretinal fluid. So, no, like any other cancer pathway, this needs to be seen within 2 weeks, and it's the same for the wet AMD patients. Actually, door to needle time is 2 weeks. So with cancer patients, we normally need to get them in within 2 weeks, and that's what we do. The on-call doctor would only be interested if this was a MAC-on retinal detachment, which hopefully you'd agree is not, because you've got kind of pigmentation, and clearly, although there's elevation on the retina, this does not look like a retinal detachment. So good, excellent. And these are the kind of things we do. So the picture to the right, if you can see that, so that's kind of the ultrasound showing kind of a lesion, mushroom-shaped lesion back of the eye. This is what I was talking about. When you see a lesion which is choroidal, you can see the retina kind of coming on normally, and then bang, it just goes right up, because there is a lesion in the choroid that's pushing everything forward, and there is subretinal fluid on top as well. So this would really make you worried that there is a choroidal melanoma. And most of you would have, I've often screenshotted this and put it on the group. We would use something called the Moles criteria, and essentially these are the scores that you give to the patient. Sometimes you won't know, for example, if there is enlargement, because the first time you've seen the patient. You might not be able to know if there's subretinal fluid, if the lesion is quite far away and you can't ultrasound, you can't OCT it, but you can often ultrasound these patients. You can see if there's orange pigmentation and what the shape is. And the scores really are that if you've got anything more than 2, which actually is quite easy to get, then the patient is high risk, and anything more than 3 gives you a melanoma. So you could very easily see if you score, some of those are like 2, just on a couple of those, even though they're kind of indeterminate, you can very easily get to the melanoma bit. And then we would, of course, send the patients to Moorfields for evaluation. They're very tough when it comes to referrals. They want to see kind of the ultrasound result. They want to see a picture. They want to see fundus autofluorescence, and preferably an OCT if you've got it over that. So if you just send the referral without those things, it will get rejected. And essentially, treatment very much depends on the patient, how old your patient is, what they wish, where it is. If the lesion is small enough and accessible enough, you can use brachytherapy, where they put a radiotherapy plaque in order to shrink down the tumor. But if they're a bit bigger and they're not in a rich area, then you might need to do an enucleation, because if you're not careful, you will get, without any treatment, there's high risk of metastasis. Don't forget the choroid is the most vascular part of the body. What you don't want down the line is these melanomas going to the liver, which are at very much risk of. So there are several options there to manage these patients. I would say majority are plaque therapy, and then probably the second commonest is surgery, but occasionally there are other kind of measures I've mentioned there. No treatment is kind of quite unusual. So if you've got a very, very elderly, ill patient, you think the condition is, the patient is not going to outlive the condition, then you would probably wait out, not put them through anything. Okay, so very well done. So majority is getting most of these patients. This is a really tough case. It was shown to me by one of the registrars, and so just to go through it slowly. So patient was in the eye clinic for an unrelated lid issue, as in unrelated to what I'm going to show you. And then when you look at the back of the eye, there's something to see. And when you press on the eyeball, the lesion goes away. So this is the lesion. So you can see that. All right. So hopefully you can see the arrows should point to it. These kind of protrusions that you can see here. Okay, in the back of the eye, and when you press on the eyeball, the lesion goes away. So uh, here's your choice. Ian's going to put them up. Oh, only three has come up. You get away with that. There is four, but that's fine. The answer is still there. So anyway, the fourth one would have been a choroidal nevus, which is not correct. So anyway, so you've got to choose between the three. Ian's giving you a bit of a easy one this one. So is it a retinal detachment? Is it a tear? Or is it vortex vein varix? And the answer is yes, 65% are correct. So retinal detachment does look like protrusion, but the protrusion doesn't look like that. You can normally see a corrugated surface with a retinal detachment. It's not so localized, and there were two kind of things there. But the real clue is, I mean, you could be forgiven when you think it's a retinal tear, although with a tear you'd see a flap, or you would see like a hole. But this patient clearly didn't have that. You could so what this is a vortex vein varix, and when you look at these patients, they've got these lumpy things in peripheral retina. Essentially, they can present in each quadrant, but when you look at the lesion with your kind of 90D or whatever, if you press on the eyeball, the lesion disappears or gets much smaller. And here is a picture of kind of a similar lump, which with pressure you can see. So that's kind of the lump there. It's like a teardrop shape subretinal tube with a green arrow. And when you press on it, you can see that it becomes kind of a lot flatter. I know in real life, the 3D is much better, but I know you can't see it on here. So I'm not saying go and press on the eyeball if you see a patient with a retinal tear, but because a retinal tear, as I say, will look like a flap, a retinal detachment will be really obvious. But these are the kind of locations. So essentially what a vortex vein varix is, it's a benign dilation in vortex vein ampulla, and you can just see where the ampulla are normally situated. Obviously, there's anatomical variation. So that's the kind of like the optic disc, and the ora serrata is kind of where you can't see because it's very far. It's kind of halfway between the nerve and right to the periphery of the retina, and normally you can't see them at all. But if they're dilated, they will look like that, and often they cause kind of confusion because people think it could be melanoma, or it could be an eccentric membrane, or it could be a nevus. But as I said, if they're in the right about location, tell the patient, I'm sorry, I'm going to press on the eyeball, press on the eyeball, and you will see it very nicely just emptying. That's what you're doing with the pressure. You empty the kind of the vortex vein ampulla, and then the lesion disappears. Good, tough one. So still most of you got that right, which is quite good. Moving along. So this is a 23-year-old female. She's highly myopic, and she comes with sudden loss of vision. So what I've shown you with this is kind of I've shown you the areas of abnormalities. Okay, so you've got yellow arrows and blue arrow. All right, and then that's the right eye, and then in the left eye, I have kind of put a circle around the foveal area, which you'll be able to see. Okay. Next, we're going to look at an OCT. So you've had a good look at that. That's what you can see in the right eye over the macula. So you can see a hyperreflective lesion in the back of the right eye. And hopefully, as you go through the scan, you can see a area of subretinal fluid on that side. Okay. So that's in the right eye. So the question is, what's the most likely cause of vision loss in the right eye? Is it a choroidal neovascular membrane, blue arrow? That's in the right eye, remember. Is it lesions in the retinal periphery, which were the yellow arrows? Is it optic atrophy? Can we look at the optic nerve? Or is it retinal vein occlusion? So hopefully Ian's going, yes, all of those. So no easy passes on this one. guys, to see which one you think is that. Okay, so yes, excellent. Again, you know, most of you got that right. It's a choroidal neovascular membrane. Now, I haven't called it wet age-related macular degeneration. She's 29 or 23, whatever she was. So this is not age-related. Clearly, something odd is going on. Remember, the reason you get a choroidal neovascular membrane is because there is a membrane called Brooks membrane. If you don't know what that is, please look it up. It's a very thin membrane that separates the choroidal vessels from retinal pigment epithelium. And anything that damages that Brooks membrane can cause abnormal blood vessels from the choroid to come in. The commonest cause of damage to Brooks membrane is age, wear and tear. So you get blood vessels in your 60s and 70s, that's what you call wet age-related macular degeneration. But lots of other things can damage the membrane. Laser burns, infection, trauma, high myopia, inflammation. So lots of different. So this patient has got something going on which has weakened the Brooks membrane, and you've got that lesion come through, hyperrefractive lesion. So that's the abnormal blood vessels from the choroid coming into the retina or the macular area, causing reduction in vision. And you know it's a CNVM because you've got subretinal fluid, which is following it. The optic nerve looks fine, and obviously there's no retinal vein occlusion because there are no hemorrhages. The yellow lesions, I think we're gonna no, we're not gonna come to us. Actually, I'll tell you what that is. So this patient is myopic, young, and the yellow lesions relate to a condition. Actually, you might be. It might be the next one. So I'm not gonna say that. Actually, let's see. It might be the next. Oh, oh, sorry. Excuse me. Okay, fine. So yes, okay. Before we get into, I was getting ahead of myself. So then you looked at the left eye, and there was a yellow circle, which I highlighted. So I want you to let me know the OCT on the left macula I didn't show you, completely normal. So what did the yellow circle was surrounding? If you can't remember, this is the yellow circle in the left eye, okay? So that's the circle. And is it a choroidal neovascular membrane? Is it a macular exudate, normal reflex, or a very large cotton wool spot? So Ian, can you bring up the, thank you very much. Okay, let's see where we are at. Yes, normal reflex, excellent. When you see young patients, have a look at the back of the eye. You see this kind of reflex, as you just saw here, in there. It can't be a choroidal neovascular membrane because I told you the OCT was normal. So OCT of the macula cannot be normal if you've got these blood vessels protruding through the choroid into the retina. I can see why you think it could be a macular exudate. Exudate tends to be very focal and very yellow, kind of like almost like the text color that you can see, and like in dots rather than kind of like a whole circular area. If you look at this, you know, that is a very typical picture of a reflex, and you will see this in your young patients. If you examine kids looking at the back of the eye, you will see this reflex like that. And obviously it doesn't look like cotton wool because no cotton wool is kind of donut shaped. There's nothing in the middle, so that wasn't the right answer. Now, what is the overall diagnosis in this patient? Punctate inner chorioretinopathy, myopic macular degeneration. Idiopathic choroidal neovascular membrane means that you just have the membrane but nothing else. The clue here of hypertensive retinopathy is looking at the yellow spots. So I think you either know this or not. So is it punctate inner chorioretinopathy, myopic macular degeneration? She is a myope, high myope. The hypertensive retinopathy and idiopathic CMV. Ian puts the hold up. Okay. Yes. So a bit of a even split. In fact, most of you thought myopic macular degeneration or myopic degeneration. It's not unreasonable to think that. The answer is punctate choroidopathy. That condition is often characterized by small punctate lesions, as you see, throughout the choroid. Normally it's bilateral. In the left eye, there are lesions peripheral, which we didn't get pictures of. Myopic macular degeneration is another good answer, but the lesions tend to be kind of a lot larger than that. So if you ever see a patient who's very highly myopic, you see really large swaths of areas which is degenerated in the back of the eye, where kind of the retina is degenerated. So you don't get these very tiny yellow dots in the choroid, and it's not hypertensive retinopathy because the nerves look okay, the blood vessels are not tortuous, there's no other features really. Idiopathic choroidal neovascular membrane would be correct if this was the only feature, but obviously not in this case. Okay, we move on. So case 6, doing well. So again, this was another case. These are all patients, by the way, that I see in clinic. None of these are lifted off internet. So, who says East Sussex is boring? So this is a 54-year-old gentleman who presents with increasing vision loss in the right eye, pressure is 3, and he had trabeculectomy a few days ago, okay? So just look at that. So what you see, the big picture is obviously temporal, and what you can see here is nasal, all right? So, and this is the other eye, which is untouched, okay? So you see that macular OCT is normal in that one. Right, so what is the diagnosis? Is it retinal detachment, eccentric central serous retinopathy, a choroidal melanoma, or a choroidal detachment? So let's go back to the picture. So is it, if you put up the poll, retinal detachment, eccentric central serous retinopathy, choroidal melanoma, or a choroidal detachment? A bit of a tough one, to be fair. So there are a few things that it could be, but hopefully the answer would be the clues that I've given you. Choroidal detachment, 43%, retina, 46%. So most of you thought one or the other. Good that none of you, well, very few of you thought melanoma, because that would be a very large encircling melanoma, and it's a differential you think about, but the history tells you pressure is very low, and when the pressure goes really low, you can get choroidal detachment. Now, the difference between choroidal detachment and retinal detachment is choroidal detachment, the area is very smooth. There's often history, so the patients have recent surgery or something like that. They don't always have that surgery, but often there's hypotony. So, but when you look at the detached areas, it's very smooth in shape. Whereas retinal detachment, you can see corrugations on the retina, and you can just see folds within the retina. So, and you can kind of see shifting fluid, whereas you don't see any of that with a choroidal detachment, okay? Now, actually, this, and it's not eccentric CSR because eccentric CSR doesn't present, you don't get CSR this big. And when you get CSR, you often pick it up on the OCT, and it's kind of very much within the bigger macular area rather than this far out. Now, I'll tell you a little thing. This patient actually didn't have trabeculectomy, okay? But I thought if I put the other condition, because I didn't get the condition either. So this patient had cataract surgery a couple of years ago. He was very hyperopic, about +8, +9, axial length less than 20 millimeters, and he just presented with increasing macular edema in the right eye and these detachments. And actually, what he has is a condition called uveal effusion syndrome, which is very rare. And you get this condition in hyperopic patients, just comes on. For some reason, it's to do with the way the venous, the fluid leaves the retina and it can't. and treatment is very, very difficult. You have to operate and make scleral windows for the fluid to leave. So that's not, so anyway, so this is what you actually have. But you will look, this will look exactly like the kind of picture you will see if somebody had hypotomy after surgery. Okay, fine. So we're going on to short cases now. I'm very aware of the time and need for questions. So here's case number 1. So you can see two lesions. I've got yellow arrow and a pink arrow. So the question is, which lesion is abnormal? Okay, so I mean, obviously both are abnormal, but which lesion would you worry about? Or would you think, oh my God, what is this? I have no idea what this is. Is it the yellow one or the pink one? So here you've got 50-50. You can't ask a friend. You can't ask me to eliminate you because I will give you the answer. So I think maybe with these ones we give 10 seconds. So are you about the yellow one or the, again, these are East Sussex cases. So some said pink, some said yellow. So the yellow crew were right. So the pink arrow shows a myelinated nerve fiber. So as you may know, so it is obviously not normal, but it's not kind of an unusual finding or something that you're not seeing. So it just looks like a very large, weird-looking cuttable spot. The whole of retina is filled with melanin. Okay, so myelinated. The whole of nerve fibers are myelinated when you're born, or when you're a baby, basically in utero. And as you're born, the myelin just completely goes away. So by the time you're born, there should be no myelin. So myelinated nerve fibers happen because certain bits don't regress or don't go away. And that's why you see that. So it's kind of more of an embryological issue. The second lesion, we think, is probably a toxo lesion. It's very well circular, and you can see a blood vessel going through it. So that's the abnormal lesion there. Luckily, it's away from the macula. It doesn't need treatment because it's not causing any inflammation. But if it gets activated, then we would need to treat it. Toxoplasmosis needs treatment if it's near a blood vessel or if you've got symptomatic vision change. So that particular one doesn't, but that's definitely the more abnormal lesion. Okay, so here the question is, which lesion is circled? So I have circled the lesion here, which is yellow. And if you don't worry about if you see the disc, it's not temporal to the disc. Obviously, we are looking nasal to the disc. So the thing that you see temporal to the disc actually is the foveolar vascular zone. And if you look very, very carefully, you can see it's normal because you have got a small black area, which is avascular, and it's about 1/3 of the size of the disc. So that's what foveolar vascular zone should look like. And then the bits around it, you can see kind of choroidal flush, obviously, and the microaneurysms there, which is abnormal. But I'm looking over here where the yellow thing is. You can just see some things over here showing. And this is the corresponding area for the other eye. So are these abnormal blood vessels or new vessels? Are they collaterals? Are they microaneurysm, or is it ERMA? Again, a tough one. So let's see which one you think it is. Move it across if you need to see. So obviously this might mean that you need to have a bit of a knowledge on fluorescein angiography. So an even split because obviously it's kind of quite difficult. Microaneurysms tend to be just like dots, okay? Because what a microaneurysm is just a capillary dilation. If you can see my arrow, Ian, can you see the arrow pointing? You're on mute. Anyway, okay, fine. So if you can see the arrow, that's a microaneurysm. It's just basically, normally you can't see capillaries in the back of the eye, but if you can see like a dot, then that's a capillary dilation. And clearly, this doesn't look like that. Collateral vessels tend to happen after retinal vein occlusions, and you can see them in the retina, but they look a lot more squiggly like that. So the differential is between IRMA, intraretinal microangiopathy, or new vessels. And it is really hard to differentiate those two sometimes. But the clue sometimes is when you do fluorescein angiography. Normally, when you do fluorescein, ERMA doesn't leak, but new vessels do. So the correct answer here was ERMA because there's no leakage. And what ERMA means is you've got these channels that are opening up, and it just shows that your diabetic retinopathy is progressing to the next stage. Okay. Right. Hopefully, an easier one for you. So, patient with cataract. What kind of cataract is it? Nucleosclerotic, cortical, anterior capsular, posterior capsular. And if any of you, let me actually go back. Ooh. Okay, let's have the poll again. Did you put it up? Sorry, I didn't say. Okay, yes. So again, most of you guessed it. It's not nucleosclerotic because it's not all over the nucleosclerotic is like the whole of the lens. Cortical would present as lines or spokes, which is rather kind of which is not present here. Anterior capsular would really be on the anterior capsule. So this is deep and at the back. So this is posterior capsular. So again, most of you got that right. Well done. Nearing the end. Oh. Okay, so this patient, interesting patient. I think this is our last question, so I've saved the best for the last. By the way, what you see here is what I was telling you exudates look like. So you can see it's very different to macular reflex. So you can see they're just yellow. I mean, they're often not this big and circular, but you can get sarcinates, obviously. And they're yellow, and they are kind of present like so. So the question is, what kind of treatment has the patient had? Have they had anti-VEGF, macular laser, radiotherapy, or vitrectomy? So Ian will put that up. I just got to speak to somebody very quickly because I think they want to look up. Just hold on 2 seconds. So Ian will put that up. I'm trouble with the housekeeping. Okay, so anti-VEGF, macular laser, radiotherapy. So quite an even split, but majority wins. Let me tell you what is radiotherapy. So those of you who are eagle-eyed would have seen this very large abnormal mass around the optic nerve. So this patient has choroidal melanoma, all right? And treatment for this, as I mentioned, is enucleation, which obviously the patient hasn't had because they still have the eye, or radiotherapy. Now, when you do radiotherapy to these patients, they will get radiation retinopathy. So you can see the lesion in the back of the eye is much smaller, it's not as pronounced, but the nerve is starting to look pale, and radiation retinopathy causes ischemia and damage. So this patient actually has vision of 6.6 when they first came. And of course, now with radiation retinopathy, the vision is perception of light. So they've got macular scar, they've got all this exudation. The fovea is completely ischemic. I mean, if that scar wasn't there, if you did fluorescein angiography, you see a very big foveolar vascular zone. So you're going to lose your vision, unfortunately, but at least the melanoma is treated and it's not going to spread. And I think that brings us to the end. So anti-VEGF, actually, so let me just go back up. Anti-VEGF wouldn't make the situation worse by giving you exudation. Vitrectomy wouldn't do it for this condition anyway, but would not cause this either. So the answer is radiation retinopathy. Right. I think we're done. Shall I stop sharing?
Yeah, stop sharing. I'm going to try and join now. On that last patient, how old was the patient on the last one?
Last patient, the patient was very young, 22.
Really?
Yeah.
Blimey. Well, thank you very much.
Abroad for many, she was going abroad and she presented with that, and unfortunately we had to put her treated and yeah. But she's doing well, you know. I said we just with these ones, you've got to make sure actually that we refer them to oncologists because they do blood count and liver ultrasound, and they monitor them, I think, for about 5 years. And you really want the oncologist to do that, because if that spreads and you don't pick it up, it's a disaster.
Yeah. Well, thank you very much. That was really interesting. And yeah, I
I mean,
tried
I
to.
think I'm really hoping you get feedback, Ian, because I don't need to do interesting cases if people want
Well, I will.
than this. So please let me know.
If anybody has feedback, they can either email me from irbeseg gmail.com or on the WhatsApp group. I've only got one question at the moment, and I know you're still at work, so you want to get home. So this is there's a couple of questions. So one of the questions early on, what makes the halo around the spindle? That was from the first case.
It's a reflex, isn't it? It must be the way the light reflects. I'll find out. I'll find out. Let you know. I mean, I don't. I can just tell you it happens in children up to a certain age. Whether it's to do with the thickness of the retinal nerve fiber layer and how it reflects off that, I don't know, but that's a good question. I'll find out later.
Why is Avastin used?
Actually, I could quickly put it in my chat GDP and get the answer, but that's your style.
Do you do that? Do you use?
No, no, I should have done that for the talk though. Anyway, go.
Why is Avastin used after choroidal melanoma radiation treatment?
Good question. So we used to only use it if the patient had macular edema. Again, as I mentioned with radiation retinopathy, if the foveal vascular zone is gone, the vision is not going to come back. But a lot of patients were getting macular edema, and Avastin was helpful to get rid of the macular edema. But in fact, recently, they have said that we should have patients have 3 Avastins a year if they've had choroidal melanoma which has been treated. And I imagine the reason for that is because you want the patient not to develop abnormal blood vessels in the back of the eye. And even if there's no macular edema, there seems to be a benefit from Avastin treatment for 2 years. They give it 3 or 4 monthly in order to, I would imagine, stop the blood vessels coming in, because what you don't want with these patients is really bad ischemia, new vessel formation, then they get new vascular glaucoma. So they have an eye that doesn't see, but then it becomes painful, which is obviously nobody's interest.
So why Avastin and not Lucentis or Eylea?
Oh, very good question again, because Avastin works in a very similar manner to all the other agents you just mentioned, but it costs £40. Whereas, I mean, Lucentis is probably 150, Eylea 500 upwards. I would imagine Vabysmo similar. So actually, a lot of patients have Avastin treatment. One, because it works, and two, because it's the cheaper drug out of all the other, and it's just as effective. So if you are not NICE compliant, then patients who decide to go private, for example, have Avastin because it works very similarly and is much cheaper. And also for anything else that, for example, NICE hasn't covered or the regulation hasn't come on or something like that, but they need an anti-VEGF, Avastin will be our first go-to drug because it will do what the other anti-VEGF does. The only thing with Avastin is that with patients with chronic disease like wet AMD, diabetic retinopathy, vein occlusion, you will have more injections over time. So I'm not going to go to this now because we'll be here till 10 o'clock. So very quickly, basically, if you've got, somebody might be thinking, well, why don't we just use Avastin on the NHS and save loads of money? And that's because if a patient has a condition that is NICE approved, then from a medical legal point of view, you have to offer them the licensed drug, not the unlicensed drug. But if they fall outside the license or outside the label, then you go based on evidence. But that would be a whole different talk. But for this condition, there's no NICE guidance, and they want anti-VEGF, so we'll use Avastin.
Cool. Well, thank you very much. There's no more questions. So I know you're desperate to get home.
Blocking them. That's fine. Thank you.
So, but thank you very much for
Thanks,
talking.
Ian. And thank you all for coming. And please just let Ian know, or just in the WhatsApp group, if you want different style, let us know. We will have peer review at some point. And I'll try and speak to you and see if we can have ground round like we did before. But I can do lectures if you guys prefer to this. Okay. Thank you very much.
Just say goodbye. So I'll just say I'll get the certificates out within 2 weeks, hopefully this weekend, maybe next weekend. I think our next speaker is Mr. Qureshi, who has promised and keeps putting off, but I will let you all know. But Shah, thank you, Mr. Qureshi.
Just while I have you here, Ian, when are you going to do your YAG blades at all?
I think we said September. We said
Okay. All right. Okay, fine. Thank you, Ian. Here's
what?
everyone.
Care of. Cheers. Bye bye.